So hi everybody, it's Lynda Keane here again, and I have Ollie with me, who this is part 2 of Ollie's chat. So we're going to talk slightly differently this time. We learned about Ollie and what he did and how he came into being a hydrotherapist. So today we thought we'd have a little journey slightly differently. We're going to actually, to start with, look at aging joints and sort of what happens in the musculoskeletal system. So hi Ollie, lovely to see you again.
Hi there, Lynda. Yeah, thank you very much. Yeah, aging joints.
Yes. So so let's start there. As we get older, you know, people are always asking about how we can help. And you know, both you, I, and sort of anybody really that works within this industry will understand that working in the water is just a phenomenal place for people with the aging joints.
Yeah.
But, so yeah, I'm going to hand it over to you and let you tell us a little bit more about, from your perspective, how we can work with these individuals and what we can do.
Okay. Right. So aging joints. So as we grow up, I'm just trying to think of the best way to explain it, but I think probably if I explain it in the nicest possible way I can, as we get older, we effectively dry out. Yep. We're a bag, and you know, in the nicest possible way, we're all a bag of fluid. And if we, as we grow up, we dry out. We've got wrinkles. Our hair goes grey. It gets a bit more straw-like rather than it nice and smooth.
Yourself.
Yeah, exactly. You know, in the local park, you see children jump off the climbing frames and land and bounce around and with no problem. Now, if I jumped off a climbing frame, I'd probably hurt myself because I haven't got as much squidgy shock absorption inside me. And all the fluid inside our body is it's called thixotropy, which is basically when fluid is still, it becomes very thick and sticky, and it's just like a pot of paint that you paint on the wall. You know, when you first open up a pot of paint, you've got to stir it before you paint on the wall. Yeah. Well, that chemical process, that's called thixotropy, and some paints are thixotropic, which are more thick and sticky. You have to stir it a lot more before you paint on the wall. Some are less. And that's basically the same within our joints. So the fluid can get a little bit more thick and sticky. It happens a little bit more in inflammation. So what I'm trying to say is that a lot of people, if they are of the older persuasion, they'll often say to me that in my physio practice that, you know, getting up in the morning is blue murder, or if I sit still for too long, getting up to go to the loo, it hurts. But by the time I get back from the loo, or by the time I've had a shower and started moving about, it starts to ease off. I loosen up. And that's effectively because they started moving and stirring a paint pot in their joints, effectively moving the joints. If you've got stiff hands, getting them moving helps loosen them up, and then it's like that if you have after
COVID, isn't it? This is going to be happening, and not just with the older population, but with COVID, we're all moving around a lot more, and everybody's saying that their range of movements aren't the same as they were beforehand, and they're aching a lot more. So
yeah,
I think
definitely. I mean, it is. It's everybody. We're all the same, and we're not a species that has been very well engineered to be still. Yeah. You know, we have to move, and you know, we've evolved for millions of years to move around the place, and it's really only in the probably last 20 years or so that we've been so sedentary. I could sit indoors all day. I could order my food from Tesco's and not move out my house. Yeah. To survive. You know, my survival is so easy nowadays that I don't have to move. And unfortunately, human beings I think we are, as a species, inherently lazy. We try and find the easiest way to do things. You know, I rather than carry bricks from one place to another place, I use a wheelbarrow, which is mechanically easier to use, or I'd use a little truck to do it, like a little mechanical truck, because I'm ingenious. Human beings are ingenious enough to make things easy for ourselves. So yeah, anyway, so we're easy. It's very easy for us to sit down on the sofa all day watching TV and eating whatever we want.
Mhm.
So anyway, the point is that movement is important. So and the more we move, the better we will be in our joints, in our muscles, in our everything. Now, so that's part of aging joints. The other part of aging joints is, as a lot of you know, about arthritis and other conditions like that, age-related conditions. Now, I want to debunk a couple of myths actually with arthritis, because it's really, I hear this an awful lot, and it's really common for people to think that arthritis hurts. I don't want to have arthritis because it hurts me. Well, you need to be very clear about this. Arthritis doesn't necessarily hurt.
No.
Of course, it can hurt. You can have pain in your knee because of arthritis, and you might need a knee replacement, for example. But it doesn't always hurt. There's so many different people out there that have got arthritis that don't have any pain at all.
And only ever find out if they end up having an X-ray and someone says, "Oh, you've got arthritic whatever." So yeah.
Exactly. And then I've also treated many people that have got arthritis on a scan. They're going to go for a knee replacement or a hip replacement. You get them to do an exercise program, like a prehabilitation, to get you nice and strong before you have the knee operation. And they're out of pain, and they don't need the knee replacement.
Yeah.
The actual physical findings of the arthritis hasn't changed, but they're not in any pain anymore. Yeah. So it's a lot more complicated. Pain, and as we get older, is infinitely more complicated. We give it credit for. I've actually got this little infographic about this, if you're interested, about a study that I'll explain. So if I share my screen, I'm going to quickly share my screen, and here is a infographic of a very, very good article in 2015. And it's a Brijinki. I can never pronounce this name.
Mm-hmm.
And yeah, as I said, it's published in 2015, and it's basically the prevalence of degenerative lumbar spine imaging. So basically, they've taken X-rays and MRI scans. I think it's actually an MRI scan findings. That's right, of people's backs who do not have pain. So they're asymptomatic individuals. That means that they don't have any pain at all. And if you can see this picture, it says disc degeneration. People under the age of 20, there's 20% of people have got disc degeneration at the age of 20, under 20, and they're not in any pain. And if you just go up the ladder here, you can see, I don't know if you can see the arrow that I'm pointing at here. 80% of people over the age of 50 have got this disc degeneration. And that does not mean they do not have any pain. So we need to rethink this. We need to rethink the narrative that we talk to our patients. Or we've got arthritis, or you can't move, you can't bend, you can't do anything. You must be in pain. That's really is not the case.
No, I mean, I have that myself, because I'm 60 now, and I go to doctors, and I've had various X-rays, having had a pretty serious fall a couple of years ago, and they say, "Oh, age-related, degeneration, age-related arthritis," and I'm going, well, there's a surprise. I've worked on my feet all my life, and that you're telling me that, it's like something I don't know, not something I do.
That's exactly it, actually, there, Lynda. So I hear that a lot as well. So you've had an accident, and you've got back pain because you've had an accident, and they've done an image scan, and they say, "Oh, it's just arthritis." But it's actually, it's not very nice to say things like that, because it's degrading the pain that you're experiencing. It might not be. It could be the arthritis. Don't get me wrong. Arthritis, at the end of the day, inflammation in the joints can hurt, but it's not necessarily. It could be the muscle spasm that you're having.
That's what it was.
Yeah. So I'll just click off of this, because I could talk about that. Stop my screen share. Often back pain, for example, is some of the pain is to do with muscle spasm. As a matter of fact, have you ever had cramp in your leg?
Yeah.
Does it hurt? Of course, it's really, really painful. And a muscle spasm in your back is a protective mechanism, a reflex to stop you, to brace your back, to protect yourself. It's a reflex reaction. It's muscle spasm. It's really, really painful on its own, let alone anything else.
Absolutely.
So the point of what I'm trying to make aging joints is that, yes, we do get arthritis and degeneration as we get older. We dry out a little bit as we get older, but that doesn't necessarily mean we're going to be in pain, and it doesn't necessarily mean that's going to be our problem. Having a proper investigation by someone, a professional who knows what they're talking about, is important to work out what's going on and the best way to help you. But inevitably, the best type of treatment is movement. It really is movement. And there's an X-ray image of a professional rugby player's prop. He's a professional rugby player's knee who had horrendous arthritis, and he's playing professional rugby without any pain. But the argument to that was that he's very strong. And again, you do exercises and prevent someone having a knee replacement. You do exercises. The stronger your limbs are, the less, the thought is the less pressure goes through the joints. It's a lot more complicated than that within the how the nerves work. But at the end of the day, the fitter you are, the less likely you are to have pain.
And then, to then bring that into the water, of course, you then add the properties of water and the physics of that. You've got the buoyancy, which then decreases that sort of pressure on the joint as well. So a perfect place for somebody who has got the arthritis, has got the aging joints, to go to get the exercise, which again is 360 degrees of resistance, not 360 degrees around the joint rather than the actual resistance. It's a phenomenal place to put people to desensitize so they can exercise without the pain. I think that's what I'm trying to say.
No, you're right, and that's actually that is the barrier, because you've got to think about what the barriers to exercise. For some, let's just argument say knee replacement or a knee arthritis.
Yeah,
it really hurts to exercise.
Yeah,
so it's hard to get strong enough and to work your muscles to get physiological changes, which is you've got to work it quite hard. So because your knee hurts, so you can't put that amount of resistance through it because it's stopping you because of instincts of avoiding things that cause you pain. So so the pool is an excellent way to do it. So you can work your muscles without actually putting too much pressure, the actual compressive force is going through your joints. So yeah, fantastic way to exercise people with aging joints.
Yeah. Is there any particular exercise that you think would be good?
For if you want to make physiological changes to muscles to strengthen your muscles up, you have to work them to a high enough intensity to make it really hard for them. In an ideal world, there's an analogy. One part of this metaphor is FIT principle: frequency, intensity, time, and type. Time and type. And the intensity of it is really, to get strong, you have to work to failure or to close to failure. And to make that, it's really actually, that's one of the hard things about being in a pool. Almost not negative, but it's the harder thing to do in the pool, because buoyancy resisted exercises is not maximum level. Buoyancy resisted exercises are very good at control and quality of movement, which is to do with the nervous system.
Yeah, retraining, isn't it?
But it's drag exercises. So imagine you put, for someone who's got knee replacement, you put a flipper on him, and he's or her, and he's kicking forwards and backwards with the flipper as hard as he can. You've got, and the movement, he or she's put a maximum amount of force that they can through the water, but the actual limbs moving slowly. There's no compressive forces, but you're working your quadriceps and your dorsiflexors and your hamstrings as you come back really, really hard. If you do that for a minute or two, no matter who you are, you're gonna your hip flexor is going to be working really hard. All your other leg muscles are going to be working really hard. So my tip with these drag resisted exercises and frontal resistant exercises like that is to don't do just 10 times. Do it until they start to feel tired. So it might be you're doing it for 30 seconds to a minute, or it might even be 2 minutes, depends on how fit and active your individual. Well, it's not even about that. It's actually how much effort they put into it. Yeah. Like if you put in maximum force right from the start, which you may not want to do, you might want to build up from 50% to 60%, right? And then now for the next 20 seconds, look at that clock up there, 20 seconds, you're going to give you 100%, keep going, keep going, keep going. and then say, right, and then slowly start to reduce.
Mm-hmm.
Not only that, you're working your trunk stabilizers to keep your body still, and all the other muscles as well. So you're working everything. It's fantastic. That is a brilliant exercise, and you cannot recreate that type of thing on land.
No, absolutely. And it usually comes as a surprise to people, doesn't it? The individual, so when you take them to that sort of fatigue level and that, or close to fatigue, I get quite surprised, A, at how quickly that can happen in the pool, you know, but I couldn't even feel it. It's like, you know, I felt like I could keep going, but my leg just sort of went, it's like they just completely went to fatigue. So yeah, it does. It surprises them a lot. So
it's also really good because it is part of, you know, you're constantly observing and looking at the assessment side of things. So if someone is kicking with one of their legs and their body's all over the place, they can't keep their other foot on the floor and all this sort of stuff, and then they use their other leg and they're fine.
Yeah.
You know, you then start to think, okay, well, there might be some other muscle imbalances there in your around the pelvic back area, you know, whatever, you know, around the hip joint. You know, and if you work on these stabilizing muscles more, then that also helps. So it's all part of the bigger picture.
Yeah. And I think you see it more in the pool, don't you? You see that imbalance. You see the whole body swaying and not being able to control, because on the land they've got the gravity, or they're sort of holding on, or they're on a piece of machinery, and it's everything's sort of stabilized and locked down. Whereas in the pool, it's
100%. I totally agree. It's so lovely to treat people in the pool, because you can I think do a more thorough assessment to these sort of individual nuances, because we do compensate really quickly and easily.
Absolutely.
People.
Okay. Just thinking on joints again, and we've just sort of covered a bit on the pain and the lower back, and we've just now spoken about the shoulders. Because shoulders are quite tricky, because a lot of people sit there and go, well, how can you work the shoulders? Shoulders are out of the water. Yes, you can squat down, but, you know, you've got horizontal, you've got vertical. So what sort of, like, working with the shoulder, you know, adhesive capsulitis, frozen shoulder, or any sort of like impingements or something, what do you sort of recommend or suggest or see, or just talk us through a little bit of that, if you can.
Yeah, no worries. I'm just trying to think the best way to phrase the answer, really. I suppose shoulders can be quite complicated and quite simple at the same time. I know I kind of totally contradicted myself.
I think water does anyway, doesn't it? Water does contradict in many ways.
Yeah, it does. Yeah. Well, I suppose. Yeah. And then
relax. No, stay still. No, do this.
Yeah, exactly. No, so if I take the conditions differently, so let's just say a rotator cuff, like a muscle, just say a muscle injury. So the way that you're just really simplistically, if you do resisted movements and things like that, and they hurt, then, well, any action, no, it's not even that. I won't go into the assessment of a shoulder. Actually, I'll go into the actual treatment. So if it is a rotator cuff, then actually gradually it'd be like you straining a hamstring or a calf muscle or any other muscle. Really, you've got to gradually build up the tolerance to movement, the resistance work, and then start building up really heavy. So the thing is it's hard to do it above unless you're lying down, if you sort of mean. So, but you can still do sort of shoulder flies, and you'd use drag, and you can do press ups in the water where your hands are on the floats, and that's a brilliant control exercise, because at the end of the day, you've got the rotator cuff muscles. You've got, you know, 4 of them, one on top, one underneath, one at the front, and one at the back. Now they all kind of do merge into each other with the tendons and things like that, and then you've got this thing called a rotator cable, which kind of attaches them all together near the head of the humerus. But my point is that it's the control, the neurological control. If you just think about the engineering of a shoulder, you just think that there's only 13% of the ball touches the socket. The socket is actually quite small.
I know. Shouldn't really work, should it?
Yeah. Now, the ligaments have got to allow me to reach right back here. So the ligaments don't actually, when I'm like I am now with my arms down, the ligaments aren't holding my ball in its socket at all. They might be helping when I play rugby and I'm right at the back here, but they're not doing anything. So the only thing that's holding my ball in its socket now is the fascia, the skin, and the muscles. And my muscle tone is probably just working on the muscle at the top here. It's probably just working maybe 5%, 10%, just to stop it falling out. And as soon as I lift up a weight, it would obviously activate more. So muscle timing is immensely important, like how the neurological system works. So that's the great thing about the working in the pool, because you can challenge using floats and loads of buoyancy resisted exercises to work on the control of the whole ball and socket through the range. So if I'm like doing a press up here and I've got my floats and I go out to the side as far as I can, you can't see my arm, but if I go out to the side and then back, then I'm working the control through horizontal flexion, extension, this type of movement. But then I could also go up and down, round in circles and different positions. I can move my arms in different positions. I could, like, you know, I could put my hand out, reach my hand, doing these type of moves. And you can do that stood up, lying on your front with your head out of the water, obviously, or a snorkel on or something. And then you can't, it's difficult to do it backwards because your arms are behind you. They don't kind of go behind you very well. So muscle control work is really good, and strengthening. And you've got to strengthen through range. And if you do it so it's absolutely agony painful, the neurological, when you have pain, your body responds, whether you like it or not. You can't help that. And often the muscles might tense up, or they might not be functioning as efficiently as they possibly can be. So try to do exercises which are I find more beneficial doing the exercises. They might hurt a little bit, but hardly anything. There's not going to be, if they're doing it into agony, it's just going to make the pain worse in their shoulders. It's going to make their maladaptive movement patterns worse. And that goes with the same with impingements. So the three classical ones for shoulder is impingement, frozen shoulder, and rotator cuff issues. There are others, of course, and there's different levels. I mean, impingement's a tricky one. There's 12 bursts in your shoulder. It could be, what's being impinged. It could be lots of different things that are causing impingement. That's, anyway, I won't go on to that. But at the end of the day, the impingement, if you lift your arm up, it can pinch up here. There's like a little hook on top of, that's called the acromion process. It's like a hook, and then the ball and socket move. And as you lift your ball up, the theory is that it pinches underneath this little socket. I mean, there could be, it's a bit more complicated than that, but that's a general impingement. So if you keep pushing it and lifting their arm up and it hurts them, what you're doing is you're squashing this little bursa, and bursas don't like to be compressed.
Yeah.
If you've ever had pain on the outside of your hip, it's called a trochanteric bursitis. And if you keep lying on that side, it hurts even more and it doesn't get better. If you keep pinching it and squashing it, it doesn't like it.
Yeah.
The reason for a bursa is just to stop friction against the bone. So again, don't push them into pain. Go slightly out of pain and then start to build up. Also, you need to work for impingement your shoulder blades as well. It's not always the case, but it is relatively common that your shoulder blades get stuck, because as you lift your arm up, your shoulder blades move around your rib cage sort of in a sort of rotation pattern, and the only way you can recreate that is lifting your arm up. So if you do that passively and it works, or you can do some rotation work in your thoracic spine, or do some scapular work. When you're doing press ups, for example, you can actually make sure they protract their shoulders rather than just using their arm.
Yeah.
And frozen shoulder is a tricky one. Again, I would suggest if you push it into pain, they just react against it. It causes suffering unnecessarily, I think. So
I say sort of like, to stay this side of pain. I said, if you get to the point where you want to punch me, you've gone too far. That's not the idea. So it's sort of like draw back from that. You want to be sort of this side of the pain. You can go into that exploratory, isn't it? That exploratory where the body's sitting there going, well, is this okay? Can I manage this? And as long as they're in that level, then they're going to get the sort of right physiological responses. Anything beyond that, and it's body's going to go, I'm not going there. Well, exactly. It just turns up. Of course it will. I mean, we're a sensible organism, that we avoid things that hurt us. And if
you lift your arm up and it hurts, the muscles are going to go into spasm and it's going to make it worse. So yeah, frozen shoulder is a tricky one. There's lots of different types of frozen shoulder. Sometimes their arms might be stiff. They get in the warm pool, and they'd be diagnosed with frozen shoulder by lots of people. They get into a nice warm pool. They feel lovely and relaxed. They just feel fantastic. They hold onto a float and they just allow their arm to float to the surface, and it goes. I've seen it. So they've got frozen shoulder, but their arm actually moves properly when they relax. As soon as they're out of the pool, it tenses up again, and that's not a true frozen adhesive capsulitis. Well, even that phrase is difficult to use nowadays with the adhesive capsulitis. But anyway, regardless, that we all know that term. So sometimes it's almost like a muscle spasm. There's other research, well, not research. There's surgeons that say that one of the procedures they used to do is called an MUA, manipulation under anaesthetic. So as soon as they give them general anaesthetic, they knock them out. Their actually arm moves in full range. So that shows that it's not adhesive capsulitis per se. It's that when they're awake, when they're awake, it tenses up again. Totally unconsciously. It's not they're consciously trying to do it. Their brain has, for some reason, gone into protective mode, and their muscles have gone all tense. To try and reduce this protective mode sometimes can help for that type of people. Again, but we don't really know enough about adhesive capsulitis. It's kind of linked a little bit to I don't know if you know of Dupuytren's contractures, when one of their fingers gets tense and they can't straighten their finger. Anyway, so that's kind of some of the tendons or the muscles tendons have contracted. Well, that's kind of been linked to the frozen shoulder. It's like everything's, the muscles and tendons have all contracted. And as I recommend, you just do what you can really, and maintain as much mobility. If you catch it early, you can maintain as much mobility as you can.
And I think also then, by, like you were saying about going into the water and people then being able to move, whereas they can't on land, psychologically that has a massive response as well. So they suddenly think, oh, it'll work in the water. So they the guarding becomes a little bit less. And if you can do it, over a few weeks, then hopefully the guarding will just sort of relax, and then they will be able to move their muscles again. Much better than going to the consultants and getting either an injection or surgery, even worse. So I've seen it happen. Exactly like you just said there, Lynda. It's reducing that fear of movement, thinking, oh, my arm does move like that, oh my gosh. And that's the same with back pain, it's the same with hip pain, leg pain. I think giving someone a confidence to be able to move is massive. For some people that's hard. They do guard and protect an awful lot. Not everybody, again, but it's not it's a generalization, but and I'm not trying to say it's everybody, but there are a lot of people out there that does happen with. So giving encouragement as well, getting the psychology side of things working. Absolutely. And that sort of, that feeling in the water, and maybe you can sort of like explain a little bit about the sort of the nervous system in the pool, whether you can do that in layman's terms, but what happens to us, what happens to the nervous system that makes it actually relax a lot more by being in water.
I mean, truth be told, I don't really know. I don't really know exactly how it works at all. I mean, I don't know if anyone does really, but
I was going to say, does anybody? But it does, doesn't it? I mean, it's sort of like you go into the pool and the nervous system relaxes so much more. And I sort of say part of it is because the whole body's being touched. Whereas if you go and you lay on the treatment couch on the plinth or something, and you sort of put your hand on someone, the nervous system knows exactly where that hand is. It knows exactly, if you put it on someone's thigh, you know yourself as sort of like wherever you are, someone touches you, you know where you've been touched. But in the water, because the whole of the body's being touched, the nervous system sort of going, well, I know I'm being touched, but it's everywhere. So it sort of relaxes a little bit more on the area that you're trying to treat, or that might be more fired up by the pain. I mean, that's sort of my explanation to it. It's not quite so scientific, but
well, you're right. Obviously, it is sending a lot of signals to your brain, isn't it? Because you're in water. Not only is the mechanical actual pressure on there, you've got the heat as well, haven't you? As well. So there's all sorts of pain gate theories and all sorts of stuff like that we could go into. But it's about does it mask some of the pain as well, which means that you can exercise more efficiently?
Yeah,
perhaps. And if you're not scared, as long as you're not scared of water, and the person thinks that they're in a nice, relaxing environment, again, many people, if they're a bit scared of water, the first sort of session is making them a bit more confident, and then they start becoming more confident, and then you can start building up the exercise tolerance and things. But there's the nervous system is an incredibly complex, multi-directional, multifactorial organism. So little things like I don't know, stress is a classic example. If you just had a huge argument with your family or something like that, your muscles get tense, and if you have that just before you go in the pool, often people say stress and pain are directly related. When they're stressed, their pain gets worse and things like that. All their muscles are all tense. You've got to spend a little bit of time maybe calming down, chilling out, relaxing, or doing some really decent exercise, which then releases your endorphins, and that then relaxes your muscles afterwards. You get nice muscle relaxation after an intense exercise. So.
I mean, that's another thing, just going back to sort of like we were saying about the aging joints, but the aging population in general, by being in the pool, they can exercise for longer as well. So on land, it's sort of, they might not be able to do a full class, they might not be able to go and do aerobics or anything on land anymore because of the pain, because of the joints, because of the general sort of aging of the body. But in the pool, they can keep going for so much longer. They really can. So I think that as well has its benefits on people's psychology, as psychological health, and as well as their actual physical pain health. So,
yeah, definitely.
Yeah, good. Okay, let's sort of move this into a completely different arena now, and we'll talk about sort of the differences between working shallow water and deep water. I know that in most hydro pools don't actually have a deep aspect, but perhaps we can sort of discuss a little bit about the sort of the physics of the water and the difference of the depths. I will because I am very privileged, I do have a deeper, it's not deep because I can still stand up in the deep end on tiptoes, but I do have a deeper end to the pool and the shallow. So if I've got people that come to me that are non-weight bearing, I can actually start them off in the deeper water and then gradually transition them as they come to partial weight bearing, sort of like down through the levels of the pool. So I feel very sort of blessed and very fortunate that I do have that. But let's sort of like maybe talk a little bit about the sort of the physiology of what happens when we go into the pool. So the different depths have different reactions when you're standing, don't they?
Yeah. So when you, I mean, I'm going to state the obvious a little bit, that when you're in the pool up to your neck, obviously the water's supporting you a lot more, so that there's less pressure going down through. Let's say if you've broken your ankle, for example, and you're non-weight bearing, or you've broken your leg or something, and you're not really allowed to put weight through, and you've had the plaster taking off, obviously, and it's been a bit of a terrible injury and you're not really able to walk. So that would be, maybe 90% of your body weight is being supported by the water. So there's only real 10% downward force going through. And as you get shallower to ankle deep, maybe 1% when you're at ankle deep, or 5% when you're ankle deep. So, there's a lot of research actually that was done a long time ago. It's an awful lot of very good research was done a long time ago, but because they were trying to work out, NASA and things like that were trying to work out how much pressure was going through for astronauts. And, you know, the closest environment they could get to back in the 60s and stuff, 50s and 60s was in the pool. So that they did all sorts of what happens to your blood pressure and your and all this different stuff. And what they found is basically, as you are, most of the stuff they talk about sternal notch, so it increases your the fluid. I won't go into the specifics about numbers, but essentially the fluid that comes from your leg, as you go deeper in water, the pressure of the water, the body of water obviously is heavy as you keep going down. So the pressure of the water is greater lower down around your feet, and it gradually gets less and less and less up. And they've done in these experiments, they did it in a foot per foot of water. And so if you're in chest, there's a lot of fluid that comes because the pressures of your foot is greater. It presses on your foot harder. The fluid comes out of your legs into your chest cavity, which means there's more fluid in your chest cavity, which means that there is a greater demand on your heart, and because it's engorged with fluid, blood obviously, and it's expanded, so it has to work harder to contract. And it doesn't actually, the rate it doesn't increase, but it just has to work harder to actually pump the fluid down because the fluid is getting pushed up. So it increases the work on your heart, and obviously your lungs are all full of fluid, so it means that they have to expand, and the thought is that it makes it more challenging to breathe, but it would probably be only minimal difficulty in breathing. But the point is that there is the ventilation perfusion mismatch, so that means that the amount of blood per oxygen in you, there's more blood than there is usually, so it's harder for it to work. Anyway, so that's kind of what happens really. So that means you've got to be very careful with people with cardiac conditions when you're in the pool, especially unstable cardiac conditions. If people are short of breath, there's lots of contraindications, again I won't go into now, but there is, you do have to be, when you're working with people who've got medical issues, you do really have to be careful and know what you're talking about. Because these physiological changes you can't help. That's just the way that the body works when you're in the pool. Absolutely.
And I mean, one of the sort of, I say, discussions, I suppose, that I have is they say about how people with high blood pressure, it's not so good being in the pool as to people with low blood pressure. But then part of my sort of thought process is, well, it's more of an issue if they don't know they've got high blood pressure or low blood pressure. So how can they actually know that that's a precaution and something they need to consider if they don't know it? Whereas if it's sort of regulated by the GPs or something, then it's not quite such an issue, and they can be managed. So I would think that these things become a bigger issue for the population that actually don't know that they have that condition in the first place. So it's being aware, isn't it? As you said, it's being aware of everybody, especially if you're going in and treating somebody on a one-to-one basis.
I mean, the practical advice I would suggest with that is that obviously make sure that the medical professionals, the right medical professionals, do an assessment. I mean, whether that's looking at the thing is that within aquatic physiotherapy, we have like GPs might say, they can go in the pool, no worries, fantastic. You know, they've got this unstable cardiac failure, they can go in the pool. But the problem, no disrespect to GPs, they're fantastic people, but they don't understand the physiology of immersion. So you've got to be careful by having someone, even a consultant orthopedic surgeon might not necessarily know how the physiology works. So you know, an aquatic physiotherapist knows how the pool works, and so, you know, an assessment by them if you're unsure would be preferable with regards to. But yeah, I mean, I won't go on about that, but it is important if you're not sure to get
stick within your remit, stick within what you're trained to do, what you're 100% happy to do.
Yeah.
You know, otherwise refer out. And that's part of being professional as well, isn't it? If you're not sure, refer on, refer out. So definitely.
But perhaps you've hit the nail on the head there, Lynda, is that, you know, there are people with medical instabilities or something that you don't know about.
Yeah.
So someone could be in the change rooms after an aquatic exercise, you know, class or something like that, and have a stroke.
Yeah.
Because they've had a blood clot somewhere, and being in the water's pinged it off into their brain, and now they've had a stroke. You wouldn't necessarily know. I don't mean to scare people, but you know, that is a possibility. You know, it's one of those risks that we have. But that's when observational skills are extremely important. So if someone is in the, like, watch, you know, one of the pieces of advice is watch someone get in the pool. Really important, because if they're sort of walking down some steps or the ladder or something, and they have breath and they start becoming short of breath, they haven't actually done any exercise, they're actually short of breath being immersed in water, then probably need to get them out.
Yeah, alarm bells.
Why are they? Yeah, that is alarm bells. Why are they all of a sudden becoming short of breath and that's because of the fluids being pushed up into their lungs, and their body's not really tolerating it very well. So really don't do exercise. There's, you know, people are looking, just the way they look, it's difficult to be specific, but you know, if they're looking a little bit ill and grey, you know, it is a high risk environment, and people do need to know that. It's easy to get complacent about these type of things, but we mustn't be complacent. There is a hazard there. It's brilliant, don't get me wrong, and as you will know, I love aquatic exercise, but you know, we've got to be aware that there are risks. So yeah, but going back to deep water stuff versus shallow water, I mean, you are lucky that you've got a pool with the depth, the deep bit in it. You know, I worked for many years in a pool that was 1 meter deep all the way through. And we had a drain, which was slightly deeper, which I used to use quite a lot. But I do like the deep water stuff. You can do so much more in a deeper pool.
I love assessing, vertical assessment in deep water. I think there's nothing like it, because they'll sort of rotate. If they're stronger on one side, you'll find they'll suddenly gradually rotate around, and I go, oh yeah, you're stronger on your sort of your left hamstring than you are on your right, or your quadriceps, or
Lynda, you're breaking up though, Lynda.
Oh,
I'm so
sorry. Oh
yeah. You kind of went all slow then.
Oh. Yeah. Is that better? Is it stable again? I'm right.
I think, were you talking about like the assessment side of things, like when they twist around in water when they're in the depth and things?
Yes, I was saying that I love assessing in the deep water, because that you can see the imbalance in the muscles so much easier.
Yeah, 100%.
Yeah, so it's fabulous. So it is one of my favorite places to do that. And that, you know, we were talking about the spine earlier, and that stretching, that elongation of the spine. So you've got that sort of that nice joint spacing by being in the deeper water. So okay, Ollie, I think we've covered lots and lots of different topics and different areas. And if anybody wants to sort of like to carry it forwards and even to ask any more questions for the two of us, then they can get hold of us here at A.R.E.A, and we'll just invite you back.
Thank you. Specific, exact questions. Oh my gosh, I'll have to read up on them.
That's it, yeah. Well, both of us probably. But yeah, so it's been an absolute pleasure talking to you. You know, hopefully I'll see you again in the not too distant future, and I will definitely be picking your brains when it comes to this PhD after you saying the other week to me. So yeah, hopefully it'll be nice actually if we can get involved together and actually do some research together. I think it'll be amazing, because again, it'll be the two worlds, you know, two worlds colliding. So I think on that aspect alone, it'll be a very interesting perspective.
Yeah, I'm really keen to promote aquatic exercise, aquatic activity, and I'm one of the ATACP research leads, and I want to promote it as much as I can, help in any way I can. Yeah, no, it'd be fabulous, absolutely. So with that, I will bid you a fond farewell, Ollie.
and let you get back on with your day. Hopefully, we've had a few internet issues with our little chat, but we'll draw this one to a conclusion and say thank you very much, and thank you for everyone for joining with us and sticking with us, and you know, hopefully see you again soon.
Well done if you've made it to the end.
Yeah, absolutely, absolutely. So thank you, Ollie, and take care, and I'll chat with you soon. All right.
Bye then. Bye.
Thank you. Bye.